Okay, so should we make a start? So first of all, I'd like to thank the TOF Association for asking me to do this talk, which was on the basis of a single clinical encounter. And I was asked to talk about long-term GI complications of esophageal atresia and Tracheo-Oesophageal Fistula, which struck me as a singularly unprepossessing title, not designed to draw the audience. So hence, what you've got is something a little bit, probably more relevant to day-to-day life, given that this condition is not terribly common and that each of you may not have that many under your care, whereas young adults that choke, vomit or reflux encompasses them and the broader picture. So let's start very simply by talking about what we ask patients about, dysphagia. And what do we mean about dysphagia? Dysphagia is difficulty in eating, though I think that's the first disconnect straight away is when we talk to people about dysphagia, we ask them, do you have difficulty swallowing? And when you ask someone to have they got difficulty swallowing, they mean this bit. And what do we mean? We mean that bit. And it's very important at the beginning to try and distinguish between oropharyngeal dysphagia, the bit of getting the bolus over the back of the tongue, and what we, I think, are all talking about otherwise in our clinical practice, which is true esophageal dysphagia. And the history is very, very important. And I'm sure this is teaching you all to suck eggs, but talking about the duration, whether it's intermittent symptoms, what sort of things people are having difficulty with, what are the ancillary circumstances at time of stress. So, for instance, someone with a long, intermittent history of high dysphagia, feeling of a lump in the throat with no alarm symptoms, it's almost certainly going to be globus, and they don't necessarily need to be investigated for anything. By alarm features, I mean things like hematemesis, weight loss, anemia, as you all know. Those are the things that might point you rather more to investigating the problem. So right at the outset, whether you're dealing with a young adult who's had a TOF repair or a young adult who hasn't, let's be quite sure what we're talking about, what symptom we're talking about. And dysphagia, in my view, doesn't really cut it because it encompasses so many, I think, mistakes at the outset on behalf of us as a profession. So when you're thinking about, well, where is this pathology? What are we trying to localize? How are we going to find it? The best person to ask, or the best thing to ask, is the esophagus, because it's very good at localizing. So in 3/4 of patients, it'll localize the pathology to within 4 centimeters, not very long. So if a patient says it's here where it gets stuck or slows down, they're more likely than not to be right. And it's pretty uncommon that you get paradoxical symptoms of high lesions causing distal symptoms or vice versa. So ask the esophagus, you'll get the right answer. Now, I suppose I should put in a disclaimer here. I'm an adult gastroenterologist. I see people from the age of 16, 17 onwards. I do not do TOF repairs. I'm not going to talk to you about embryology, big sigh of relief. I'm not going to talk to you about how to do a TOF repair because I've never done one. I see people years and years later, after their surgery, when they may or may not have symptoms. Having said that, I'm going to put up the one slide about TOF that you might expect to see from someone who deals with it all the time. If only to say, don't worry about it. There's lots of different types of esophageal atresia or fistula. It doesn't really matter when you're going into the adult world, other than possibly the distance between the two disconnected ends, which does have a bit of an implication as to the incidence of complications in the future. But essentially, once that's repaired, you're dealing with the same sort of problem, and the vast majority of them are in any case of one particular type. So 9 times out of 10, it's going to be one type anyway. So I think this classification is more for neonatal surgeons than anything else. What is important is the incidence, which is 1 per general practitioner, I'd have thought, something like that. So something that you're not going to see very often, and something, to be honest, we don't see that often at secondary care level either. So when you follow these people up into adulthood, and there are some good studies out there, it's clear that they do, as one might be able to predict, have more problems in the upper GI world than the general population. Everyone might get reflux, everyone might have dysphagia, but they're more likely to. So 1/3 of them will have gastroesophageal reflux symptoms of some sort. That doesn't mean daily, it just means that they will complain of them at some point, compared to less than 1 in 10 of us in the general population. And a lot of them, a startlingly high number, will complain of dysphagia at some point. They don't all come to medical light. And of course, it's a relatively uncommon symptom in the general population. When you investigate that group with TOF or OA repair, you find high levels of hiatus hernia, Barrett's, I mean that's 10 times the general population, esophagitis, again about the same, and anastomotic stricture, again about the same, but they will present exactly the same way as everybody else, i.e. mostly intermittent dysphagic symptoms, occasionally obstruction, and occasionally with the complications of obstruction and aspiration pneumonia. So at this point it would seem appropriate to turn to the national guidelines for follow-up of these patients, so we can get rid of that in one word. There aren't any. And anyone who tells you, oh yes, they must do this or they must do that, is purely singing from their own hymn sheet. They may have some good data to suggest that this would be a good idea, but at the moment there are no guidelines, and I'm pretty keen that it stays like that for this reason, that whilst all of them have abnormal tests, really without exception, not all of them have symptoms. And as soon as we say, oh yes, he's had TOF, therefore we must sort of treat him with kid gloves, we sort of start medicalising what may be someone who's completely normal and has no symptoms. More than that, I'm quite keen that we don't think of these people as someone who's a TOF, but someone who has, in the past, long distance past, we're talking adults, have had a repair of a congenital abnormality, and now they are an adult, and they may or may not have problems relating to that, but they may also have problems relating to other things. They are, after all, adults who've had a past history, and we come across people who have past histories of all sorts of things, but we don't label them necessarily as TOF or this or that. It's a very common problem. We see people, my other hat on as in inflammatory bowel disease, we see people with Crohn's disease who every time they come to hospital, almost irrespective of what symptom they come with, it's shoehorned into a diagnosis of flare-up of Crohn's. And it's even nice to think that we can treat people who've had a previous TOF repair as just somebody who's had a previous TOF repair with a new set of symptoms that we need to try and tease apart, rather than trying to be frightened of them because they've had something quite complex and difficult in the past. So I thought a little bit of sort of anatomy and physiology revision might be useful, just to think about that sort of quite startling statement that 100% of them have abnormal manometry. There's not many 100% and 0% in medicine, but that's one of them. And remember that the esophagus is not just a cylinder. In my world, it's the most important organ, but even so, it is a complicated organ. It has an outer circular muscle layer and an inner longitudinal muscle layer, the combination action of which causes peristalsis. But the top half is striated muscle, the lower half is smooth muscle with a transition zone. So it's not really surprising that it's a very complex organ, that once you start fiddling with it surgically, something's going to go wrong with it. It's worse than that. The top half and the bottom half have different neurological supplies, both coming from the midbrain, but they are different. And it's the action of those together that produce that peristaltic wave, so the esophagus contracting one bit after the other. It doesn't take much for that to go wrong, even without the introduction of a surgical procedure. How does that work? Well, going back to your physiology days, you might remember Auerbach and Meissner's plexuses. These are basically neural networks that run between the various layers of the esophagus, between the mucosa, submucosa, and circular muscle layer. And the esophagus is the only part of the gut where that neural network runs through all the layers. The rest of it, it's confined. These are the things that send little signals down the esophageal muscular wall to cause contractions that coordinate with each other. It's, if you like, its own enteric nervous system. So you've got little neurons that fire independently. So they will fire independently even when a patient is brain dead. This will still be working because it's not all under brainstem control. There is some intrinsic electrical activity. Even for someone who's got no history of TOF repair or anything like that, the advent of reflux can, so this is normal grade 1 and grade 3 esophagitis reflux, can severely affect how these neural networks work. They are attacked. Gastric acid is pH 1. If I put some of it on this desk, by the time I stop talking, there'll be a little dent in it. It is powerful stuff, and when it gets into the wrong place, it causes damage. And reflux in us, who've hopefully not had any TOF repairs in the past, even in us, it will cause micro damage to your esophagus. It will then start causing hyperstimulation of these plexuses with a concurrent spasm, and then later it will destroy those plexuses so that the electrical activity goes. That's in someone who hasn't got a predisposing factor. It's worse than that because these two nervous system inputs that I told you about rely on all sorts of different neurotransmitters. Acetylcholine, nitric oxide, vasoactive intestinal polypeptide are just 3 of them. There's about 30 have been described. It's a hideously complex and still not very well understood mechanism. So not surprising really that meddling with it at day 1 of life isn't going to lead to long-term manometric normality. And in a way, it's quite a surprise that a lot of people do end up with very, very few symptoms or just intermittent ones. Normal transit down the esophagus isn't linear either. What you're not doing is taking a little clump bolus of mushed up bread and dropping it down, and it goes down under gravity control with a bit of peristalsis. Because you've got this transition zone, this is a picture of some radio-labelled bolus going down the esophagus. If you plot it down the esophagus, there are 2 distinct phases. It shoots down the first bit, then it almost stops in that transition zone between striated and smooth muscle. Then it goes on again and then stops again at the gastroesophageal junction whilst that opens up. So if you plotted a sort of a functional map, if you like, it would be like that. So quick, slow, and it's deviation from that pattern that determines symptoms. That, although it looks genuinely abnormal, and you're all there thinking, well, that's not how my sandwich went down at lunchtime. It is. It's when you don't have that that your brain senses an abnormality. So these are high-resolution manometry pictures, and this is clearly not a tutorial on high-resolution manometry. Suffice it to look at the colours. The top left one is normal, and that's a bolus being squeezed down the esophagus, time on the x-axis, and that's going down normally. The other 4 are from people who've had a TOF repair in the past, and those are the sort of the commonest versions. You can see an aperistaltic esophagus. So up here, the one that really does rely just on gravity, and ones where you get diffuse distal esophageal spasm, so uncontrolled spasm at the wrong time, but all the muscles contracting at the same time, and very localized junctional spasm. Of course, these are going to cause symptoms. So I'm a bit of a fan of William of Occam, 13th century friar, the chap who gave us Occam's Razor, which basically says if all other things are equal, the simplest explanation is the best one. So when you've got someone in front of you, and they've had a TOF repair in the past, they're still presenting you with a bunch of symptoms. And if they say, I'm getting heartburn 2 or 3 times a week, especially with curry, not really relevant that they had their TOF repair. It might make you think, oh, okay, the gullet, that's something I should be thinking about. It's still, the common thing is still going to be reflux, and they should be treated as such. So what other conditions do we have to think about here? Okay, we've said already that reflux and peptic strictures are 10 times more common in this group, so clearly they should be uppermost in your mind, and they're quite common. But there's this relatively new kid on the block, eosinophilic esophagitis. It's got nothing to do with TOF, but again, they're part of the human race, and they're likely to get it. 1 in 1,800, maybe. I'll talk a little bit more about that. Achalasia should be bottom of your chart, because it's so uncommon, but of course it does present in young people, and it does have significant implications. And then there's this still relatively badly described entity of diffuse esophageal spasm, which was what I was showing you pictures of before, where sort of the bottom of the esophagus doesn't work very well, all contracts at the same time, and it doesn't propel food through to the stomach at a good rate. And yes, of course, they still have an increased risk of cancer. 10 times the risk of Barrett's, and therefore by inference 10 times the risk of cancer. Barrett's progressing to cancer at about 0.25% per year. When you're thinking of investigating dysphagia then, you may just be sending these people up to secondary care and say, right, get on with it, and that's fine. Or if you're investigating them yourselves, try and think, what am I trying to achieve here? Do I want an answer to a structural question? Is there a stricture? Is there a cancer? Or do I want an answer to a functional question? Spasm. Everyone's had calf cramp in their time. And when you look at the calf afterwards, it looks completely normal. That's what spasm is internally. That's what bloating is. You look at the organ, it looks perfectly normal, but there is some inherent muscular problem that is causing a dysfunction. So a purely structural test is the good old OGD. It's a very, very good structural test. Nothing's perfect, of course, and you must never think of a test as being the gold standard, but it's the best we've got in terms of structural things. For people who don't want an OGD, and it's not the nicest thing ever, there's a barium swallow. Barium swallow will pick up quite a lot of things, but barium is a hugely unphysiological liquid. It's very dense, and it can certainly shoot past sort of minor strictures without picking them up, so it does have its problems. Video fluoroscopy is very good at assessing the swallow. Hopeless, of course, and not designed to look at the esophagus itself. So there again, it's important right at the outset to distinguish the history. And then purely functional tests are things like pH studies and manometry, which will tell you much more about the esophagus's daily exposure to acid or its muscular activity. But bear in mind, even so, it's still just a snapshot in time. The manometry test takes about 20 minutes. That's 20 minutes out of a life. pH studies, 24 hours, still 24 hours out of a life. It may not be representative, but still it's probably the best we've got at the moment. And many patients with dysphagia may have 2 or 3 of those tests just to try and tie down exactly what's happening. And that's also reflected in this graph or pie chart of what sort of pathology do we find when we gastroscope people who have dysphagia. And you can see that in over half of them, we call it endoscopy negative, ghastly term, but we don't find an obvious cause. It looks to all intents and purposes normal. So things like those 4 can all look basically normal. So eosinophilic esophagitis, yes, there are some typical appearances, but they don't need to be there. Globus, well, it doesn't have anything to do with the esophagus, so not surprisingly it's going to look normal. Achalasia, well, you might get a clue and find a big baggy esophagus full of food, but it can look normal. And non-erosive reflux disease and diffuse esophageal spasm, again, you can't see the spasm particularly. It's not a very good test for that. Remember, it's a structural test, not a functional test. So over half the time, you've done the test and you say to the patient, well, it's normal. And they look at you as though, no, it isn't. There must be a problem. What are you going to do next? And you can say, well, okay, it's not erosive disease. You haven't got a benign stricture. You haven't got cancer. But we've got to tease these other things apart. So I thought just a few words about those other things, which I'm sure you're very familiar with. Peptic strictures, 10 times more likely in the TOF repair group, but still quite a common finding. 1 to 5%, depending on your study, of people with chronic reflux. By chronic is generally meant 3 times a week for 10 years or more. And probably the most important part of that group is that they have a huge increased risk of esophageal cancer, over 40 times the normal population. But in some people, prolonged reflux produces an intense scarring and therefore sort of an hourglass pinching of the esophagus, usually in the lower third, which is easily seen at endoscopy. Early ones may just melt away on a PPI. So an endoscopy, which sometimes disrupts the tissue a little bit anyway, just by dint of putting a big tube down the esophagus, plus a PPI. So we get a number of people who come along, we find a mild stricture, we think, okay, we'll have to bring you back for a dilatation, we give them a PPI, they come back a month later and it's all gone. Lovely. But the tough ones, and that looks like a fairly tough one, it's quite a longer one, will need dilatation with a bougie or a balloon, and may need several. And certainly people with a TOF in their childhood will have the likely to have multiple dilatations, but the rate of dilatation tends to drop off once they hit sort of their 20s and certainly 30s, so that they can expect to have 20 or 30 in childhood and adolescence, but then it does disappear. And it's an exaggeration, but it's the same principle as with adult medicine. If you've got someone with a resistant stricture, all sorts of things have been tried, but basically you just keep going until you win, and that might be weekly dilatations for a long time until the stricture gives up. There have been trials of injecting steroid and whatnot, but it's not widely done. Eosinophilic esophagitis, well, no one really knows how common it is because there's still increasing awareness about it. It was only first described in our lifetimes, in the 70s. It is worldwide, it tends to be more male predominant, and it can present at any age from childhood through to adult and possibly even middle age. And depending on what age it presents, it has different symptoms there, but the group we're talking about may have intermittent dysphagia, bolus obstruction, or simply heartburn. And a lot of them have concurrent eczema, hay fever, asthma, atopic symptoms. And whilst you can sometimes get these lovely diagnostic pictures, most of the time you don't, and you get very non-specific endoscopic findings, and it looks fairly normal. The diagnosis on biopsy. It's a dreadfully termed disease because it's not esophagitis. It doesn't respond to a PPI. It's got nothing to do with acid. Although as soon as we see esophagitis, we'll wheel out the omeprazole, and then are surprised that it's not working. But the treatment for that is food restriction, allergy restriction, and swallowed or inhaled steroid. And then lastly, achalasia, say 1 in 100,000, so not really worth the time of day in this context. But again, there are a lot of things that can be done now. Botox injection into the sphincter for people who really are quite frail, can last for up to a year. Very easy to do, very safe. Because a balloon dilatation, although it's relatively straightforward to do, is not safe. 3% of people will perforate and spend time in hospital with an NG tube, on antibiotics, on ITU, which isn't great if you're 80 and have 3 comorbidities of ischemic heart disease and what have you. A myotomy, if any of you are unfortunate to be enough to be diagnosed with it, a myotomy is what I'd go for under the age of 60. And then there's this new thing, POEMS, which is a per-oral endoscopic myotomy, which is basically a myotomy from the inside done endoscopically, which is just coming online now, which proves, early data suggests it's going to be just as good as a myotomy, but with fewer complications, and of course no inpatient stay or one-night inpatient stay. So lots of things that can be done. But it all goes down to a good history, distinguishing what we think of dysphagia and what people think of difficulty swallowing, asking about the circumstances to try and tease apart whether it's a chronic, an acute, a progressive or an intermittent phenomenon. Yes, of course, the past medical history is going to give you a jolly big clue. So someone with reflux and a previous TOF repair, you're going to put those two together, but still treat the individual as a new patient. And then think whether you're going to try a bit of PPI for someone who's got a decent reflux history with no alarm symptoms. Trial of PPI is perfectly valid, in fact, the thing to do. Or whether they should be referred for investigation. And if you're doing that, should it be functional, structural, or a mixture of both? Right, I think I'm out of time, but I'm very happy to take questions if we've got time for that. Please, yeah.
I don't know if it's particularly related to TOF, but...
so can you speak up a little bit?
Yeah, you said about peptic stricture. You said it was 40 times more likely to be...
No. Esophageal cancer is 40 times more likely in chronic refluxes than the general population.
So the peptic stricture...
Peptic stricture, the rate is about 1 to 5%. But no, I mean, you should, I suppose the point I'm trying to make is that reflux, regular reflux, is a really important risk factor. And I think sometimes we denigrate it a little bit, saying it's just a bit of heartburn. And it isn't. It's a lot of heartburn, and there aren't that many things that give you a risk factor of 40 times the risk of the general population. Sorry if I've misled you.
That's all right. Is there any risk if we give them a PPI, though, that we might mask esophageal cancer down the line?
Well, there is, although the things to look out for are if they're still having reflux symptoms, so that's the big one, breakthrough reflux symptoms, and the group to specifically target are the white, middle-aged, overweight, smoking, stressy males.
Is that cancer risk reduced with the PPI?
Yeah, $1 million question, isn't it? Probably. If the reflux symptoms are controlled. Any other questions at all? Okay, thank you very much.